Hello, welcome to a presentation on Refeeding Syndrome by Brittany Smith, Claire Soph, and Chelsea Varner. Our objectives today are as follows. The nurse will describe refeeding syndrome, including the signs and symptoms. The nurse will identify patients at risk for refeeding syndrome, and the nurse will apply the clinical management of refeeding syndrome to a case study. So, what is refeeding syndrome? Refeeding syndrome is a complication that occurs when a malnourished person begins receiving nutrition again. In one study, 34% of ICU patients developed symptoms of refeeding syndrome after feeding was initiated. Refeeding syndrome was first described in Japanese prisoners of war after World War II. So, what happens to the body during periods of starvation? During periods of starvation, the body aims to prevent muscle breakdown. To do this, the basal metabolic rate decreases by 20 to 35%. Also, hormonal and metabolic changes occur, and fat becomes the body's main fuel source. Without nutrients, intracellular electrolytes are depleted, and the intracellular space shrinks. Although intracellular electrolytes are depleted, serum levels remain normal due to compensatory mechanisms by the kidneys. When a patient begins receiving nutrition again, that nutrition is usually high in glucose and protein. The large glucose load stimulates an increased release of insulin. Insulin causes uptake of glucose, phosphate, potassium, and magnesium into the cell. The rapid uptake of these electrolytes into the cell causes serum levels to rapidly decline, which leads to hypophosphatemia, hypokalemia, and hypomagnesemia. These three electrolyte disturbances are the hallmark signs of refeeding syndrome. Let's look a little more closely at the symptoms of hypophosphatemia, hypokalemia, and hypomagnesemia. Hypophosphatemia can cause hypotension, seizures, anemia, and respiratory distress. Hypokalemia can cause delirium, respiratory distress, tetany, and decreased deep tendon reflexes. Hypomagnesemia can result in seizures, anemia, gastrointestinal symptoms, and hypocalcemia. All three of these electrolyte disturbances cause arrhythmias, neuromuscular disturbances, weakness, lethargy, and paresthesias. So, what are the clinical manifestations of refeeding syndrome? These include hyperglycemia, fluid retention, dysrhythmias, heart failure, respiratory failure, including failure to wean off the ventilator, anemia, delirium, and weakness. What type of patient is at risk for developing refeeding syndrome? Major risk factors include one or more of the following: body mass index less than 16, weight loss of 15% in the past 3 to 6 months, little to no nutrient intake in the past 10 days, and pre-existing low levels of magnesium, potassium, and phosphate. Minor risk factors include 2 or more of the following: body mass index less than 18.5, weight loss of 10% in the past 3 to 6 months, little to no nutrient intake in the past 5 days, alcohol or drug misuse, and misuse of insulin, diuretics, chemo, and antacids. Patients that are at risk for developing refeeding syndrome include the elderly due to poor appetite, decreased physiologic reserve, and possibly a decreased ability to prepare or consume food. Those who use alcohol chronically are at risk due to malnutrition and electrolyte depletion. Diuretics also cause electrolyte depletion, and antacids are phosphate binders. People with diabetes who are non-compliant and those who are chronically malnourished are at risk. People who are morbidly obese, especially those with recent rapid weight loss, are at risk. Those with malabsorptive disorders such as Crohn's, cystic fibrosis, and short bowel syndrome are at risk due to decreased ability to absorb nutrients properly from food. Those with chronic diseases such as cancer and HIV and AIDS are at risk due to metabolic changes. People with anorexia are also at risk due to decreased nutrition intake and low body mass index. So, what are the guidelines to prevent refeeding syndrome? For a patient with no risk of developing refeeding syndrome, such as a patient with normal body mass index and no history of disorders affecting nutrient absorption, the guidelines include 20 to 35 calories per kilogram per day. The patient should consume 0.8 to 1.5 grams of protein per kilogram per day and 30 to 35 milliliters of fluid per kilogram per day. So, for a 60 kilogram patient, this is about 1,200 to 2,100 calories per day, 48 to 90 grams of protein, and 1.8 liters of water. A patient at moderate risk has one minor risk factor, such as little to no nutrient intake for 5 days. If a patient is at moderate risk for developing refeeding syndrome, feeding should be initiated at 50% of patient requirements for the first 2 days. Fluids, electrolytes, vitamins, and mineral supplements should be based on lab values. Remember, a patient at high risk has either one minor risk factor or two major risk factors. The plan of care for a patient at high risk should include starting nutrition at a maximum of 10 calories per kilogram. For the 60 kilogram patient, this means 600 calories per day. The amount of feeding should be slowly increased for 4 to 7 days. Thiamine, vitamin B, and a multivitamin should be provided immediately before and daily for 10 days during refeeding. In addition, electrolytes should be corrected as needed. It's important to remember that feedings can be enteral or parenteral. This includes a patient with a normal diet, those on tube feeds, or those requiring total parenteral nutrition. When a patient begins being refed, the nurse should monitor vital signs and strict intake and output. Since the patient is at risk for arrhythmias, the patient should be on continuous telemetry monitoring. Due to the risk of respiratory failure and neuromuscular disturbances, frequent assessment of respiratory and neurological status is warranted. A basic metabolic panel should be drawn daily, and daily weights should be taken for the first 4 days, then twice weekly thereafter. Electrolyte disturbances can occur as long as 2 weeks after refeeding begins. Now, it's time for a case study. Let's see what you've learned. Patient J.A., a 70-year-old male, presents to the medical ICU with alcoholic liver disease, depression, and severe malnourishment. Prior to admission to the ED, J.A. attempted to commit suicide by ingesting large amounts of laundry detergent. A gastroscopy revealed several upper esophageal strictures. The patient is suffering from dysphagia and persistent vomiting. His BMI is 13.6, and his lab values include potassium of 3.2, magnesium 0.8, phosphate 1.8, and sodium 136. The physician orders TPN to be started. Let's consider some questions related to this patient's case. What factors put this patient at high risk for refeeding syndrome? The patient's risk factors include a BMI less than 14, alcoholism, malnourishment related to dysphagia and vomiting, pre-existing hypokalemia, hypomagnesemia, and hypophosphatemia, and increased age. Is the patient at no risk, moderate risk, or high risk of developing refeeding syndrome? The patient is at high risk for developing refeeding syndrome due to the presence of 2 or more major risk factors. These are BMI less than 16 and pre-existing low electrolyte levels. Based on JA's risk category, how would you initiate feedings? Due to BMI less than 14, feedings should be initiated at a rate of 5 calories per kilogram. The rate should then be increased slowly to reach the patient's full nutritional needs between days 7 and 10. For the first 10 days, feeding should be supplemented with thiamine, vitamin B, and a multivitamin, and electrolytes should be corrected per lab values. Oh no! On the third day of feeding, the patient develops weakness, tetany, and hypotension and suffers from a seizure late in the day. What electrolyte imbalances associated with refeeding syndrome could have caused these symptoms? JA is probably suffering from hypokalemia, hypophosphatemia, and hypomagnesemia. I bet you're wondering how this case ends. After discontinuing TPN, JA was hydrated with IV fluids. TPN was then reinitiated at the proper rate of 5 calories per kilogram per day, and over the next 2 weeks, his electrolytes were slowly corrected and his BMI increased to 15.6. The patient was discharged to an outpatient rehab facility. The end. Please complete the post-test and have a great day.